Very important. Small cell, non-small cell. Small cell is considered a systemic disease. So usually it's a combination therapy, chemotherapy, radiation therapy. Surgery usually has no role. But having said that, we occasionally come upon resected small nodules, stage 1 cancers, which turn out to be small cell lung cancer. Invariably, these tumors then go into the tumor board discussion. It's always a controversy whether you have to just surgery is allowed is enough, or this patient needs some sort of adjuvant therapy, chemotherapy or something, because we believe that small cell is a systemic disease. To just put in the context, it used to be practice for people with small cell lung cancer to get prophylactic cranial radiation, even though they do not have brain metastasis. If you make a diagnosis of small cell lung cancer, they would get prophylactic brain radiation to prevent the possibility of brain metastasis, because these patients treated as a brain metastasis is very frequent. So the question is very relevant. If you incidentally resect a small cancer, which happens to be small cell, is it enough just to do surgery or add some other treatment? I mean, it's an evolving concept in lung cancer, but fortunately, most of the small cell lung cancers, when you make a diagnosis, they usually have a small lung nodule, bulky lymphadenopathy. They usually have brain metastasis, bone metastasis. That is usually the common pattern. And almost always these patients have a heavy history of smoking.
Thank you, Professor Suba. And now Professor Suba is generous enough. He's giving us a third lecture, application of dual energy CT and thoracic imaging.
This is an interesting topic. I asked here and I realized that you guys do not have dual energy CT, but just sit through this talk, because I'm sure it's only a matter of time before you guys acquire dual energy CT or photon counting CT. Some basics here will be helpful when you eventually get to this newer standards. So these are the financial disclosures. So in contrast with, so far the CT we talk about is a CT scan which is applied with one energy. The energy can be either 100 kV, 120 kV, 140 kV, one energy. But if you get images using two different energies, either 80 and 120, 80 and 140, that becomes dual energy scan. The importance of finding these two energies is there are some elements which are better characterized or detected when you use this dual energy technique. The things which are relevant in our clinical practice are iodine and barium. So there are other elements which also are possible to differentiate, but in the ranges or the radiation range we use in our diagnostic images, it is not possible to separate those things. So we can do calcium, we can do iodine, we can do barium, but the best use for this one is iodine, that is more widely used, but we can also separate out calcium. To some extent, it produces both anatomical imaging and also some functional information, because we can quantify the amount of iodine, therefore the amount of perfusion. So this is based on the KH. So if the energy of the photons is similar to the KH of the atoms or elements such as iodine and xenon, then we can differentially have more attenuation from these particular elements. So I'll show you some examples so that you do not get caught up in the physics of this, but this is something which can be done and it is being widely used all over the world. So there are several ways you can get two different energy pieces. One is you can have only one tube that rapidly fluctuates between a high energy of say 120 or 140 and 80 kV. Rapidly switches 120, 80, 120, 80. By doing so, it goes around the patient, so you get the entire body with two different energies. Or else you can have two separate tubes. One tube goes around the patient in the gantry at an energy of say 80, the other one goes around the patient at an energy of 120. So you got two different X-ray tubes. Either you can have one X-ray tube switching alternately between high and low, or two different tubes, one at low and one at high energy. Or else you can also separate out from the detector level. Like we saw the patient in the example in the physics discussion, where they use two different detectors. One detector picks up the low energy photons, the other detector picks up the high energy photons. Therefore, you can separate out. That is also possible. Or else you can also have one tube. First time you go around the patient with 120, then go around the patient second time with 80. But this is almost never used. So these are the common types of dual energy techniques: single source, dual source, and dual layer. So this is the picture here. This is the rapid KV switching. The single tube goes between 120 and 80. These are two different X-ray tubes. They are perpendicular to each other and they go around the patient simultaneously. Or you can separate out the different energy photons based on the detector configuration. It is called dual layer detectors. This is the Philips one. So when you use this dual energy CT, you can get a different number of images. In the regular CT, we get only one images with 140 or 120 or 100, whatever you used. If you are using dual energy, you get a set of images. The first thing is you get the regular 140K images or high energy images for quality check images, or you can also call them blended images. Then you can construct low KeV images. You can construct the images from say 40 keV all the way to 180 or even further if you want. So we have a mathematical formula. Say for example, my hand is being imaged. Then I would say, what does my hand, how does it look on a CT scan when it is imaged at 60 keV, 40 keV or 80 keV. By doing so, you optimize for different elements within the tissue. So that's what we do. So because it can characterize few elements such as iodine and calcium, you can also get this type of iodine distribution. Then after injecting the contrast, you can subtract out the iodine. So you can do a study with after giving intravenous contrast. So that is a contrast enhanced image, but then you take out the iodine, you get a virtual non-contrast. So even without performing a non-contrast study, you can get two sets of images, one with contrast and one virtually without contrast. So these are different image series you can get. So this is an example of pulmonary blood volume image. So what it is done here is, you inject the iodinated contrast into the system, then you just map the iodine. So this is how you get. So this is the red color here. This shows the distribution of iodine into the lung parenchyma. If you think that the contrast is going through the blood, so wherever this iodine is present, that is where the blood is present within the lung parenchyma. So we can also have slightly modified images to make images more prettier and also show more anatomy. You can also superimpose other structures. This is the true blood volume image, but this is modified images. This type of images we use in our clinical practice. So when you do a CT angiogram, the most common application for dual energy CT is to perform vascular studies, because it is so easy to enhance the density or attenuation of the iodine. If you are using dual energy, you should use it preferentially for vascular studies. Therefore, you have very high contrast enhancement in your vasculature. So when you use it, it has got its own protocol. So the protocol, this is the protocol for dual source and single source. We also have Philips scanner. We have three different scanners. So for Siemens is the dual source, single source rapid KV switching is the GE, and dual detector is the dual layer detector is the Philips. So we have all the three scanners. I've given the techniques for two of these type of scanners. So one advantage of using a dual energy CT is, because you have higher attenuation from iodine, you can get away by injecting much lower amount of contrast volume. So suppose regularly you are using say 80 to 100 ml, you can easily reduce your contrast by 40%. Even by injecting less amount of contrast, still you have very good contrast opacification of your arterial system or venous system, whatever you're trying to image. So that is the advantage of using dual energy CT. So I'm going to talk about a few clinical applications. The first is pulmonary embolism. There are a lot of challenges when you are looking at pulmonary embolism studies, because in a good number of studies, the study is not diagnostic, because for whatever reason, the contrast has not reached its optimal density. Therefore, we are not confident enough to say there is a pulmonary embolus or no pulmonary embolus. Then we also have problem detecting very small emboli. Then we also have problems. Suppose say a patient with pulmonary embolus has lung consolidation. We do not know if this is pulmonary infarct or it's a pneumonia. Then we know that patient has got multiple pulmonary emboli, but we do not know how to prognosticate. What is the significance of this pulmonary emboli? Does it mean this patient has worse prognosis, or the prognosis cannot be determined? So these are some of the things. Then the other common problem is, many of our patients have multiple organ failures. They have renal failure, so we cannot give too much of iodinated contrast. So we can't even do pulmonary embolism study. So these are some of the challenges we face in our clinical practice. So let us see how dual energy helps in these situations. So this is a paper which I published in 2011, almost like 2010, yes, more than almost 15 years ago. So here, this is a regular scan. So this is with the dual energy scan. So here is the regular 140. When you use dual energy, I can play with my contrast KDD. So here the contrast is much better. So this one would have said it is suboptimal classification. You cannot assess the pulmonary embolism, especially in the smaller vessels. Whereas here, the contrast density appears better. So if you do a dual energy scan, you can manipulate the KEV. You can reconstruct virtual KEV images at whatever level you want. And if you are reconstructing these images at lower KEV, the contrast density is much higher. Therefore, the images looks much prettier. So your diagnostic confidence improves. Instead of saying it's a non-diagnostic study, you still can say, yeah, this is a good study. There is no evidence of pulmonary embolism. So patient does not get repeat study, and more importantly, patient does not need to be treated with anticoagulation. So this is a snapshot of what happens to your pulmonary vasculature density. You can say this is also for aorta also. What happens when you reduce your KEV? So here this is 140 KEV, this is 40 KEV. When you come from here to here, as the KEV is being reduced, the density of the contrast in the pulmonary arteries and aorta is very good. It looks beautiful. When you increase the KEV, the density doesn't look that good. So somebody can ask the question, we do not have dual energy CT scan, what can we do to improve the contrast density? The simple answer is reduce your KEV. Instead of performing these vascular studies, let's say 140 or 120, you can reduce your KEV to 100, and therefore you get better quality. So this is low energy CT is also very good. So this is a snapshot. When you reduce the KEV, the contrast density is good, and because the contrast density is so good, the artifacts also appear less. Though these images are more noisy because of very high contrast density, the artifacts are not as efficient. So I want to show you one particular instance where to perform a pulmonary embolism study is very difficult. That is in pregnancy. In pregnancy and postpartum women, we do not get good quality pulmonary angiogram studies because one, there is a lot of blood volume. Two, the gravid uterus will press on the IVC, that depletes the venous return, and also there is increased cardiac output. So there is hyperdynamic circulation. Because of three reasons, they do not achieve good contrast density in the pulmonary vasculature. So these are a challenging situation. Because on one hand, you want to diagnose pulmonary embolism in pregnancy because it has high mortality. Then two, it is difficult to get good quality studies. So how do we do it? So in this situation, dual energy CT is very useful. We did a study we subsequently published in JCAT, where we found that if you perform these studies with dual energy CT, the non-diagnostic studies are much lower, on the range of 10%. When you compare to the single energy, the non-diagnostic studies were in the range of 30 to 50%. To show you an example, this is a 15-week pregnant who is 190 kg, very big patient, and this is a 33-week pregnant patient with 86 kg. In this very big patient, by doing dual energy CT, we got better contrast in the main pulmonary artery compared to a somewhat smaller patient with a single energy. So more studies become diagnostic in this situation. The other important thing is you get these beautiful pulmonary blood volume images. At one go, this is how a normal lung parenchyma should look like. It's homogeneously orangish with blue and red, yellow and red. This is the normal appearance of parenchyma. When you're looking at a pulmonary embolism study, if you switch on this pulmonary blood volume images, or they're also called as iodine maps, and you do not find any perfusion defects, you can say with a high level of confidence that this patient does not have pulmonary embolism. On the other hand, if you start seeing this type of wedge-shaped defects, these are perfusion defects. If you see them on this pulmonary blood volume images, you should be very careful. Search carefully for small embolus. So this one with the small embolus here, this was not that obvious, but because we realized this perfusion defect, we can go in and detect this small pulmonary embolus. So this is the value of using pulmonary blood volume images. The other example here, this patient has got a small pulmonary embolus and then the distal perfusion defects. So looking at the perfusion defects, you can trace back to the pulmonary artery and see if there is a pulmonary defect. It is also important to differentiate infarct from pneumonia. How to differentiate? Infarct is because of lack of blood supply. Therefore, there will be decreased perfusion. When we feel it, there will be hypoperfusion area or decreased distribution of iodine. Pneumonias, on the other hand, do not have this type of perfusion. So we know that when you're looking at pulmonary embolism, there are few things which predict the prognosis. Suppose a patient has got shock, or a patient has got right ventricular dysfunction. Then this patient tend to have higher mortality because this is called the significant right heart strain. This is what we lay upon. Somebody has got, say, lot of pulmonary embolism. We look at the right heart chambers. We measure RV/LV ratio. We measure the dimensions of pulmonary artery to see if this patient is developing any right heart strain. More right heart strain usually translates to higher mortality or morbidity in the next 30 days. So if the patient also got multiple perfusion defects on pulmonary blood volume images or iodine maps, that also has a bearing on prognosis. These patients tend to have higher events in the next 30 days compared to those without perfusion defects. The other thing is contrast nephropathy. We know that we cannot give too much of iodine contrast. So one way to get around this problem is, one, don't choose an alternate state like an MRI, VQ scan. If you're forced to use iodinated contrast, use low osmolar contrast. Third, keep the patient adequately hydrated. And fourth, use the lowest or smallest possible volume of iodinated contrast, what we can use. So by doing urine scan, because you can reduce the concentration, the volume of the iodinated contrast, you can minimize the contrast-induced nephropathy to a certain extent. But this has become controversial. Now some people believe that the whole concept of contrast nephropathy may not be true because maybe it is overblown. Maybe the risk to kidneys is not that much as we thought it was. But anyhow, the one advantage is you can reduce the volume of iodine. At the least, you have the benefit of reducing the cost by decreasing the utilization of contrast media. And when you're using low contrast, you have to modify your technique. This is a technique you use when you're using lower contrast volume compared to the standard contrast. Here you use standard contrast in a hospital is 65 to 80. You can reduce it to 25 to 36 ml. So more frequently, somebody gets a abdominal steady that becomes small pulmonary emboli in the lower sections of the chest. Then you want to do a repeat chest CT soon after. So in that situation, you cannot give a full dose of contrast. So in this situation, you can do a dual energy CT where you can reduce the amount of contrast that is needed to be used. Then we can get a good quality image. So here, this was an incidental thing detected on abdomen, not very sure. We did a repeat chest CT with a filling defect here. There's also a small impact in the catalytic signal in the left lobe. The other advantage of using dual energy CT is when you're giving a lot of contrast, you keep giving contrast even after images are acquired. So that causes a lot of dense artifacts in the axillary vein, subclavian vein, in the SVC. Because in dual energy CT, we can deteriorate it using lower volume of contrast. After rejecting the contrast, we can chase with the normal saline. So that reduces the stick artifacts in the axilla, in the subclavian vein, axillary vein, and SVC. So these images look much better, the artifacts are reduced. Then, when somebody is thinking of performing a thromboembectomy, we also want to assess the microcirculation. So we know that where there is embolus, there can be distal non-perfusion filling defects, perfusion defects, but this patient can also have obstruction of the microcirculation that causes all this perfusion abnormalities. If they have this much perfusion abnormality, revascularization surgery is actually not a good thing for these patients, and if surgery is performed in these patients may have actually more adverse outcomes. So we can also do bioenergy for routine chest. I'll focus on few stuff. This is our protocol for the routine scan of the chest, that is for oncology applications. So this is our contrast volume. Routine chest can be done as standalone chest. If for oncology workup, we combine chest with abdomen and pelvis. So if you're combining these three body parts, the contrast volume is 80 to 180. The standalone chest is between 65 to 80. So I want to show one application with virtual non-contrast image. Here, this patient has got a lesion, not here, has got some bright, dense densities in this nodule, and there's also enhancing vasculature here in the lower area. At this time, we do not know if this increased densities in the nodule represent blood vessels or something else. It can be a virtual non-contrast. If you have virtual non-contrast, you subtracted out iodine, all these results are gone, but you can still see the calcium or high density within the nodule. Now we know this is a nodule which has fat and calcium, therefore this is a hematoma. So even without doing a non-contrast study, we can still virtually reconstruct a non-contrast image from these images if you do a dual energy CT scan. The other thing is material decomposition. I said material decomposition is you can separate out iodine, you can separate out calcium and other structures, other elements from the images. So here this is a contrast enhanced study. On this one, we see that there's a lot of bright nodules. There could be like really enhancing nodules, or there could be something else. When you do in the bone windows, you see that they are still dense. There's also calcium in the aortic valve. Now you remove the barium, calcium in the aortic valve is still present. You can remove the barium. So this patient aspirated barium in the past. So these are not calcified granular matter, but this is aspirated barium. So this is something which can be done. We can also estimate the iodine concentration. So why is it important to estimate the iodine concentration? Iodine concentration is a surrogate for perfusion. So this is a way we can calculate the iodine in the tumor. We can get the ratio from the aortic circulation, from the contrast in the aorta. We can estimate the iodine in the tumor in the lung. There are a number of ways you can calculate the iodine concentration. It can be absolute iodine concentration, iodine-related measurement, arterial enhancement fraction, so on and so forth. But the important thing to remember is we are looking at iodine concentration, which is a marker for blood perfusion. Few things here. Benign nodules have less enhancement or less iodine concentration or iodine enhancement compared to malignant nodules. A nodule which is not enhancing at all could be a necrotic tumor or more likely an abscess. This one has no iodine concentration at all. It's turned out to be an abscess. So absence of total contrast means it's a cyst, total necrosis, and abscess. Another example here, this is the hematoma again. Benign tumors have got low iodine concentration. You can measure the absolute concentration of iodine in this tumor per cc. Anything less than 1 is considered benign. Anything over 1 is indicative of significant amount of iodine concentration. So here is a lesion in the prevascular mediastinum. This is the thymic tissue. This thymic tissue has got iodine concentration of 1.3. So thymic hyperplasia and thymic tumors tend to accumulate iodine because it is enhancing. Whereas a thymic cyst, on the other hand, will not enhance. The iodine concentration is 0.5. On an MRI, you can see the cyst. So we can differentiate a cyst from a solid lesion in the thymic bed. And most of the time we use MRI, but for whatever reason, if MRI is not possible because of contraindications, such as a cardiac device or for a cochlear implant or something, then we can use dual energy CT. So in malignant tumor, we can also use the iodine concentration to figure out a few things. We can differentiate it from poorly differentiated cancers. We can also use to correlate iodine concentration with standardized uptake values in the FDG bed. So this is an example. All tumors, non-small cell and small cell. If you see this one, HEV max, we know that for the patients who have got aggressive cancers, the iodine concentration is higher. So for small cell, which is more aggressive cancer, the mean is also higher. So this is something which is done. But a word of caution, these are all still research studies. We do not use them in routine day-to-day practice. The routine day-to-day practice is more for vascular studies. So this is a ground glass nodule. If you measure the iodine concentration, it is 1.8. So we know this is accumulating a lot of iodine. So this one also has got a TG uptake. This is a malignant lung cancer or adenocarcinoma. And a more aggressive cancer, which is an CV6, also has got much higher iodine concentration of 2.1. This also suggests that it's a more aggressive cancer. When you have tumors with necrosis, that's a good thing to know, because if these patients are being treated with radiation therapy, intratumoral hypoxia means these patients are relatively radio resistant. So here in this squamous cell carcinoma, it is very difficult to figure out the necrosis in the center, but on the iodine maps, you can see the receptor area of necrosis. So if you are looking at central necrosis, if you are planning to treat this by just radiation therapy, you should be mindful of relative radio resistance. So treatment response, if a treatment is successful as radiation therapy or ablation or chemotherapy, the iodine concentration significantly drops because of necrosis, because it destroys the angiogenesis in the tumor. This is one way to monitor the tumors. So for example here, this is a study which showed that there are responding lymph nodes, non-responding lymph nodes. Non-responding lymph nodes, there is hardly any drop in their iodine concentration, whereas at responding lymph nodes, there is significant drop in their iodine concentration. So this is a marker to assess your necrosis or response to therapy. So this is a patient with cancer treated with primary tumor and lymph nodes with radiation. Unfortunately, this area here has peripheral higher iodine deposition, so we know that this particular area of the tumor is not responding to treatment, and this has got more still a viable tumor there because of the higher iodine volume. So we had to figure out how to deal with this one, because obviously the radiation treatment was not successful. If this is realized early on, they can read out their radiation treatment plans to improve the area. This is what we routinely use for after ablation, radiofrequency ablation, microwave, or cryoablation. After successful ablation, the tumor should be totally hypovascular. How do you know it is hypovascular? You compare this to a totally non-enhancing structure, say gallbladder. Gallbladder body does not enhance at all. So if the value here is similar to the top value in the gallbladder, we know that this is not enhancing. Similarly, the musculature should not enhance. If the value is similar to musculature, it is not enhancing. In contrast, there is high amount of contrast in the iodine and brachiocephalic artery in the SBC. So, in conclusion, DECT, I wish you guys had more experience with this one. It provides some incremental information. At the least, if you have access to UNED CT, you should do for all vascular studies. So you can achieve better contrast opacification, and you can also get away with reducing your contrast volume. And it also, in some select situations of cancer treatment, it will help you in monitoring your treatment response.